even amongst clinicians, people aren't always entirely sure what acute medicine is, but essentially I see unselected patients who are on the medical admissions for a hospital. So I see people who come to hospital with a medical problem that is undifferentiated and they may or may not be poorly to various degrees. If you're wondering, isn't that emergency department? It is different, but from your perspective, I guess the difference may be somewhat trivial. The point is that I see people who I've not seen before, and information about their past can be important. And I think the reason I've been asked really to come back and speak is twofold. Firstly, to encourage you that what you're doing is important to us, even if a lot of us don't realise it yet. Secondly, also my perspective, and it is my perspective, on the risk around digitisation. Personally, I'm quite relaxed around that risk, and I shall show you why in a moment. It has to do with just how bad the place is that we're in already. Okay, so I always either begin or end with a quote. Mary Shelley, of course, a local person. But change comes whether we like it or not, and I'm going to argue that change is a positive thing. So first of all, here's what health records looked like probably before I started work. Purely paper and nothing else. It would be the houseman's job to go and fetch physical printouts of blood results on a daily basis and stick them or copy them into notes. And then the only thing that wouldn't be in there would be the x-rays, which would be physical as well. And I remember that at university. I never worked with it. You know, you'd literally hold them up to the light, perhaps, if you didn't have a light box available. And a lot of people are still working who lived in that environment and are more comfortable in that way. Okay, so now in addition we get some IT systems on top of that before I start work. So by the time I start work in 2007, we've already got things like Clinical Viewer for eCams, which you'll recognise here, which looks somewhat on Windows 1995, 98 perhaps. And I've anonymised this. Actually, I found this this screenshot on Google, and it was not anonymised at that point, so I can only assume it was a test screen. And, you know, clearly any forward progress is better than none, but as soon as this happens, you've got a mixture of systems, both paper and electronic. And that's a step forward. That's good. The houseman doesn't have to go fetch the physical piece of paper with the bloods written on them anymore. It appears on the screen. But suddenly you have information in two separate places. And then there's a proliferation of IT systems, so that now, in addition, I have to check, or may have to check, at least these 5 extra things. PACS is our imaging software, so we can look at x-rays. That's not the same thing as Clinical Viewer at the top right there. Although the reports from PACS often always appear in Clinical Viewer, the images don't. You want to look at them yourself, so you have to open another program with another password. VitalPack is another program again with a password, which logs you out with a vicious rapidity. By the time you've been to see the patient come back, it's logged you out again already. That's separate with its own password. That's for looking at the observations, so things like temperature, blood pressure. Then ECG archive, which has no password, usually, except sometimes on some computers, and that's how you look at the old ECGs. Now that change came about because we were trying to do away with the big stack of paper on the left there, rather than getting the patient's whole old record physically arriving on the ward, sometimes in a box if the patient's been in a lot of times. We get something else called Evolve, which is the next thing down the line there, which is where all of the old paper is scanned in. So rather than a fully digitised record, we have paper, which we write in, and then when the patient goes home, those bits of paper are individually scanned in, sometimes the wrong way up, and you can look that up with another password, another login. That all takes time. And because you can't see the ECGs in physical format anymore, you have to be able to look up what the old ECGs look like, so you can tell if these changes that are present now are new or old. And then finally, Tomcat. Well, a lot of people don't look at that, but that's how I can look at echo reports, which sometimes don't appear on Clinical Viewer. And when the report doesn't appear on Clinical Viewer, it also is the case you can't see that an echocardiogram is done at all. So you're missing critical information. So you have this real mixture of different IT systems which talk to each other to varying degrees. This has happened over time. There was no plan for this to happen. Things were just added bit by bit as we tried to cope with this transition to a digital era. And what are the problems with these? Well, you should know even better than I do, but you may not have actually seen or heard of what it's like to work with this on the front line. So, first of all, information is siloed between hospitals. We don't work in isolation. We send patients over to Southampton, other tertiary centres, and we can't see what has been said or done there unless we are copied into a letter. Can't see it at all. In addition, it's not even a question of tertiary centres. For example, renal medicine is, for us, in Dorchester. So if you've got a patient who's on dialysis, their letters relating to that are all situated in Dorchester's system and is invisible to us. So we can't see what's been said. If someone's being worked up for dialysis, we don't know if the plan is for it to start soon. If someone's got poor renal function and is seeing a renal physician, we can't see if there's a plan for them to commence dialysis. Patients often don't know. Even within one hospital, we get fragmentation of information between different IT systems. So you have to make a positive effort to go looking for it. It doesn't get pushed in front of you. So if I don't check on Tomcat, I won't know that that patient had an echocardiogram. Sometimes, not always, but sometimes. And things like that occur throughout. It takes time and mental effort to pull everything together, logging into maybe 5 or 6 different IT systems for one patient. And that leads into this final point, which is that even when information has been recorded, and we're bad at recording information in healthcare, we know this, digitization won't necessarily change, not necessarily, but even when it has been recorded, it's easily missed, and that is difficult to defend after the fact if you have a problem. And that's where we are right now. Okay, so let's look at a real world example. Before anyone jumps up and down about confidentiality, again, I went to Google Images for all of my slides. And literally, I just Googled medical notes, that's it. And this is the first thing I found on Google Images that was actually a written sheet from a set of medical notes. And you can see, if you're eagle-eyed at the bottom right, this is American. Given that's the case, I'm surprised just how similar the abbreviations are. An awful lot of things are really just like what you'd see written in a set of notes now. And this looks, I could see a set of notes like this, you know, if I just drove back to Bournemouth Hospital and opened any set of notes, it would look like this. Just a few reference points straight away. So it's on paper. If you're a clinician in this room, I think you should be able to read this relatively easily. The screen's perhaps a little small, but I think you can make this out. If you're a non-clinician, I reckon you're probably looking at this screen and going, that looks unintelligible. Does that sound fair? When I open a set of notes, there may be upwards of 20 pages like this. If I'm picking up the patient, and that's from fresh, I don't know anything about them, I have to skim through that. The Royal College of Physicians recommends 15 minutes per patient on a ward round. That is generous. To read through 20 pages of that, looking for the relevant information, not miss anything, and then go see the patient and make the decisions in that time frame is challenging. We will skim, and we will sometimes miss things. But compare and contrast that to this. Even clinicians will find that difficult to read, I'd say. This is pretty much hieroglyphics. Actually, I can read this. This is a plan for a patient with asthma, and you can make it. The top one says prednisolone.
Yeah. From the Papradex.
But it becomes clear as you read it in context. Prednisolone 40 milligrams. Someone thinks it should be given IV. No, someone's pushed it out orally. This is quite difficult. I think that is asthma, continued medicines prescribed, something like that. It becomes more obvious here. That's peak flow to twice a day. That's BD. You have to know what the context is to know that that says BD. This, I worked out eventually, is NEBS 4 hourly. That says Q4 with a little 0. And that one, I think, is atrovent written twice, which is a mistake. But it's probably atrovent and salbutamol meant to be. And then this one here says keep SATs over 95%. Now, in isolation, who thinks that says 75 and who says thinks 90? Yeah, so some people would say 75, some say 95. I'm going to say right now, any kind of digital system is better than this, because this is open to interpretation. You have to know that that should be 95 because of the clinical context. Any medic would go, you don't want SATs to be over 75, you want it over 95. But if you had to fall back on this as proof that the right things were done, you'd be in big trouble. But here's the important point I'm going to make. There is not a headline case that I'm aware of, River Page might well correct me on this, but I don't have a headline case saying, here's a time when Dorset Care Record saved a life. And I don't think I will for a little while, but I think that's completely fine. And I shall tell you why. The benefit from shared care records comes from numerous marginal gains. It comes from taking less time to bring everything together, reducing duplication of work, and lowering the likelihood of missing something that was important that you could have missed had it not all been brought together in one place. And you're not going to have an awareness of the time when you didn't make a mistake. So my analogy here is that it's a little bit like driving. So you remember, probably most people in this room will have had an experience of being in a car and driving somewhere and having a near mishap, or maybe even actually having a mishap. And that journey will be memorable to you. What you don't remember is all the times where careful and conscientious driving on the part of all stakeholders resulted in nothing happening. And that's what we're aiming for. We're aiming for uneventful healthcare. So if Dorset Care Record and similar projects can contribute to uneventful healthcare, no one's going to remember that it was helpful, but it will reduce the amount of harm that occurs. That's my argument. Okay, so here are some specific examples. Right now it's very difficult to tabulate blood results in Bournemouth Hospital. It's easier in Poole Hospital. But we even have the difficulty that we can't see blood tests that haven't been done within our patch. If we can increase the size of area in which we can see blood results, we'll have a better chance for more of our patients to know whether this anemia that we've spotted has actually been present for 10 years and nothing to worry about, or whether it's brand new and we do have to worry about it, whereas right now we have to scrabble around a little bit to work that out. Anemia is a good example because very often we come across it in patients who are here for completely different reasons. And sometimes under work pressure, people just ignore it. I have to say that's true. Sometimes it's the only marker of a sinister underlying process, and if people just ignore it, that flies under the radar until it's more of a problem. Another example is kidney function. We spend a lot of time looking at people whose kidney function is less than perfect. But again, the devil is in the detail. Is it new or is it old? And having a greater chance of being able to compare to previous results is going to help us here. The visibility of conversations, essentially, that have happened elsewhere is another important thing here. Like I said earlier, we have people who go off to Southampton to have a tertiary centre discussion about what's going to happen about their thoracic aortic aneurysm or some sort of rare cancer, or go up to Dorchester and have a discussion about whether they're going to have dialysis or not. Frequently, and I realise this is heresy, but you can burn me, but you can't burn my heresy. Patients don't remember what they've been told, or they misrepeat what they've been told. And being able to see what was actually said and what the consultant seeing the patient thinks is vital sometimes. And also the patient's awareness. I mean, most clinicians will have had one consultation in their life when they walk into a patient and say, so we need to talk about this cancer that you've got, and the patient says, what cancer, what? And it just wasn't obvious to them that from the notes that the patient hadn't yet been told about this significant diagnosis, whenever it was. If the patient's gone to another centre to be told about something, you assume they've been told, and they actually haven't. Bad things can happen. And then allergies. So, I mean, I came to the workshop here 6 months ago, I think, on allergies. And it's a far more complicated thing to work out than I assumed before I came. I was pretty naive, I think. And a lot of the discussion really was about, what is the risk if you rely on multiple systems, you pull from multiple systems to tell you what the allergies for a patient are. And one system says there are no allergies, and another system says that there are allergies to X, Y, and Z, but there's a discrepancy. What I would say is that patients and their relatives say different things to different people and things get forgotten. If I have two bits of information given to me, one saying that the patient has got an allergy to something and the other one says that they don't, what I know critically is that at some point someone thought there was an allergy, and what I will do is I will ask the patient or their relative, is this the case? And at least I'm triggered to look into it a little bit. Whereas if I only have the one system to rely on that says no allergies, I may get into trouble if there actually was one. So detail on allergies is an ideal thing. I realise from going to the workshop that there's a lot of difficulty in trying to get the metadata on allergies. I understand that. If it's possible to get it, that will be tremendously helpful because allergy to penicillin, one of our commonest allergies, sometimes isn't really a true allergy and sometimes is minor, and sometimes penicillin is the best drug to give that patient. So if we can just have more information on that, that would be better than less. And the rest of this I don't need to tell you. Okay, so I will come to what I think is really the key message to give to all of you as people involved in developing the Dorset Care Record. I think if I was a non-clinician and I was coming to this, I would be anxious about what may happen, what may go wrong with the system I'm happy to develop and put out there. A bit like Mary Shelley again, what if Frankenstein does something you don't intend him to? So the sort of worries people have in mind are, what if my system displays incorrect information to the end user and that results in error? What if there's conflicting information displayed, and what if the information displayed is out of date? Am I going off the reservation too much? Is this a worry that people have had? Yeah. Okay, fine. So I said we'd come back. We're going to come back again to this apparently comfortable patient. Okay, so just take this one page. It's the first page you come to that looks like a medical note. If you Google image medical notes. Now, you may need me to read this out to you, partly because of hieroglyphics and partly because of the screen size, but let's just take record may display incorrect information. So at the top we have a neurologist entry in 2001 apparently. It says the diagnosis is limbic encephalopathy. Then at the bottom, a junior doctor, I assume, I don't know, has written leukoencephalopathy as the diagnosis. Now they sound a little similar, but they are very, very different things. So within one page, someone has miscopied and created a new diagnosis where there was one not before. Now this does happen right now in paper notes, and I'm hoping I'll get back up on this. I see it frequently. People copy things across, and they do it incorrectly. Let's take the next one. Record may display conflicting information. Alright, so I'll translate this. And prognosis is not good unless tumour can be eradicated. And the rest of it says, sadly, there's no other reasonable therapy. The next day, a different doctor, I think it's the next day, has documented a long talk with the daughter of the patient. Neurological disease is not reversible even if cancer were eradicated. Even if. It's different, it's conflicting. If you came to this later on, which one would you believe? Again, that's within one page. Okay, so next, record may display out-of-date information. Well, I couldn't get that on one page because that's somewhat difficult to do. But I can give you numerous examples from my own clinical experience. And it has to do with the fragmentation of data within multiple different IT systems. If you're a junior doctor and you're clerking someone in, this kind of thing can happen, and has happened just recently. So there's a letter about a patient on Clinical Viewer that says this patient's got mild to moderate mitral regurgitation. For non-clinicians, that's a valve problem with your heart. Mild to moderate, just monitor, nothing much to worry about. They have an echocardiogram which isn't visible on Clinical Viewer, but is visible on Tomcat, and that it progressed to be severe mitral regurgitation in 2018. In 2019, the patient gets clerked in by a junior doctor who documents on that admission mild to moderate mitral regurgitation. That is out-of-date information because that's the thing that they saw. They didn't take the time to dig into another IT system because they were pressed for time. Is that significant? Depends what happens to the patient, really. If they go into heart failure, then that's very significant. If that doesn't bother you. Okay. So, does everyone know what AAND is, by the way? Okay, right, so it used to be called DNA CPR, which used to be called DNAR, which used to be called DNR. We have to change the name every few years. Anything unpalatable, that's always the case. But it's the same thing. It's basically an advanced decision not to attempt resuscitation in the event of death, really. Okay, so during this patient's admission in 2016, an AAND was completed with the patient screened. Unknown to the junior doctor clerking in 2018, earlier in that year, the patient had gone back to their GP and said, I don't want this. Now, the rights and wrongs of that, is somewhat moot. In reality, an AAND is a medical decision, not the patient's decision, but in this case, the GP did rescind the AAND. So to all intents and purposes, that patient was still for resuscitation. They arrived back in hospital, that bit is not visible to the junior doctor. So, as is our usual practice, another AAND form was completed for that admission because that was the last bit of information, and that was not discussed with the patient because we don't really discuss when it's already been discussed once. The patient goes through that admission not for resus and they don't know it. And if that doesn't bother you. Okay, so a patient comes into hospital and they're ill, and because they're ill they can't remember what medicines they're on, and the medicines weren't brought in, or they were brought in and they were lost, but it's probably the former. This is probably a little out of date now because actually many of our juniors are now using SCR, but at that time the junior didn't have access to SCR or DCR, so they used the best thing that they've got, which is our own discharge medication list from Clinical Viewer previously. They copy that down as de jure fact. But medicines have changed quite a lot during that time. Quite a few of the medicines that the patient's been written up for, and they're too ill to tell you that they're not taking them anymore, they're not really meant to be taking, and they get given them for a few days until medicines reconciliation kicks in. These are all consequences of our mixed paper and multiple IT system. What I would argue is, as long as we're careful and circumspect about saying that the clinician has responsibility to make sure that they're happy with the information they've been given, especially given that there may be conflicts, the situation we're living in right now is inherently quite dangerous and full of risk. The only thing that mitigates for that is that, by and large, clinicians are comfortable with and aware of the problems we're living in. But that does not eliminate problems occurring, and they do occur reasonably frequently. Those problems often don't result in harm and get picked up and rectified, but sometimes they don't. So, what I'd say is we can't do that much worse than what we're doing. Shared records do have the great potential to reduce harm and improve care. But critically, it's very important that any new system does not take away from junior doctors and consultants this responsibility to check that the information that they're acting on, that they are happy. So for example, if you're given conflicting information about allergies, you still have the responsibility to check that what you're doing is the right thing. That's really my talk.
Thank you.